Okay, we're on the air. Hello, everyone. Good morning, good afternoon for those calling in from different time zones. My name is Vincent Wong from USAID in the Office of HIV/AIDS, and this morning we're going to be really presenting a few articles from the recently released supplement, Achieving 90 Squared. That's the first two 90s, Young People HIV Testing Services, and Linkage to Treatment. So I hope everybody can see the slides I'm advancing. The first one is, if there are any problems, just type into the chat. And if you've got questions during the session, just enter them into the chat, and we're going to queue them up throughout. So the supplement was really supported by FHI 360 through the YouthPower action mechanism of USAID. And that mechanism was looking, as you see here, to increase opportunities to services available to youth broadly, and in this case we're really focusing on the clinical continuum of HIV, improve the quality of services offered to youth, and engaging youth in policy making and development activities, all of which you'll see represented in the selection of presentations that we have for you today. So if you're on Twitter, you can add questions through the chat box here on the right, or using the hashtag 9090PYD. And those will be compiled, and we'll get them to the authors as we move through. My name, again, is Vincent Wong. I'm going to be moderating along with my colleague, Donna, from FHI 360, who's sitting next to me, and she'll be taking on the questions part of this. The speakers you see listed here, we'll provide a few introductions to them as we move through the papers, and the supplement you can see here. We had our guest editors, Sten Berman, Donna McCarahar, and Dr. Ryan Phelps, who was supposed to co-moderate with me this morning, but was unable to. He's out in the field this week. Critically, the link to the right is there. All of the articles in the supplement are open access, so you can access all of them. We'll be presenting only a handful of the total. So for the full articles, you can reach out to that link. So I'm just going to frame some of our thinking behind the supplement in just a couple of slides. This isn't by any means an exhaustive review, but gives some indication of where we are. We're going to expect increases in new adolescent infections globally. This came from the last UNICEF report that came out last year. And we see the global trends over the next 20 years increasing on the left-hand bar, sex disaggregated, with girls in the red and boys in the blue, and then the totals up in the gray. And notably, on the right-hand chart, we'll see on the right-hand side a much steeper incline, a higher rate of infection within Eastern and Southern Africa. And this is really related to the demographics and the epidemiology that's occurring right now, where we've got 40% of the population in sub-Saharan Africa being under 15, and a potential doubling of that population by 2050, along with the prevalence and incidence in those populations is going to drive the infection upward. So this is to say that the looking at getting prevention interventions and positive adolescents into care and treatment is going to be a critical step in trying to get a handle on this increase. And notably, about 1/3 of all new infections globally is going to be occurring in adolescents and young people. So, sorry, there we go. So when we think about adolescents and overall the first two 90s as we're focusing on here, we really have very limited data, but what we know is, and what we see is that there are low rates of diagnosis. So that first 90 is nowhere near the proportion it should and could be, and it's certainly less than the overall adult population. These are just some figures here that we've got that suggest low rates of diagnosis. The U.S. estimate recently published 2014 from Zanoni, 59% of adolescents and young PHIV remain undiagnosed. Survey of U.S. MSM put the figure at 52%, which is much lower than the overall MSM rate. There was a UNICEF report in 2013 suggesting 20% of HIV-positive adolescent girls have been diagnosed, And then through a Zimbabwe household survey that was published this year, a 2.6 positivity rate, which is pretty high for adolescent populations, and only 38% were undiagnosed previously of that population. So high rates of non-diagnosis among these groups. We've also got very limited data on linkage to treatment among adolescents and young people. The limited data that we do have tends to focus on adults, but we know from a few studies that we see poor retention associated with younger ages. And there was a U.S. study, again among MSM, showing 62% linkage to care at 15 clinics. Various factors have been posited for poor linkage among adolescents, including lack of provider friendliness. There's a correlation between older and younger ages, sex and ethnicity differences. But again, there's a lack of depth of understanding of linkage to care among adolescents. And while some of the factors may be similar, there may be different age-specific factors as well, and this probably requires substantially more study. The end results of the low rates of diagnosis and presumed low rates of linkage you can kind of see here. These are preliminary findings from 3 population-based HIV impact assessments that were PEPFAR funded, Zambia, Malawi, and Zimbabwe. And what we see here for the 15 to 24-year-old age bandwidth is much lower rates of viral suppression writ large, right? So there's an inference to be made there that people just aren't getting diagnosed within this age band and are not achieving viral suppression by being linked into treatment early enough. So 2 years ago, we started thinking about this problem, and one of the thoughts we had was it would be good to sort of catalyze some thinking around building the evidence base and getting a bit more of a focus on the issue of diagnosis among adolescents and linkage to care among adolescents. So we decided to support the supplement that you're seeing before you. Again, here it is. This was the original goal of the supplement, to provide new evidence and insights, enabling funders, program planners, researchers, and policymakers to improve and develop HIV programs, policies, and approaches for adolescents and youth. Again, the link is there. And we got a really good cross-section of papers. This is the full list of what you can find. I'm not going to go through it. You can go to the supplement yourself, but it covers community-based efforts. It covers quality improvement efforts, new interventions on linkage to care for adolescents. Most of these come from the African settings, but not all. There are 2 papers on key populations in the U.S. which are critically important and have some relevance as well for other countries. So those noted in red here are the papers we'll be hearing from this morning. And so we'll get right into it. I'm going to, where are we here? Is this, okay, so we're going to move right into the first paper, and I'm going to introduce our first 2 speakers. They're going to be Julie Dennison, an assistant professor at Johns Hopkins University, and her research is focusing on how families and communities influence adolescent health decisions, including accessing HIV testing, care and treatment, and adherence to ARVs. And my colleague Calvin Robinson, a program analyst from the Office of HIV/AIDS at USAID, and he's been managing the YouthPower project, has been instrumental in moving this whole supplement along, and is engaged in a lot of youth-related activities within our office. So take it away, you guys.
Hi everyone, and happy early International Youth Day. As Vincent said, my name is Calvin Robinson, and I'm the program analyst in the Office of HIV and AIDS at USAID. I had the privilege of serving as a co-activity manager for this supplement, as well as the youth reviewer for one of the articles that was ultimately submitted for this supplement. Today I will be talking about our process to engage youth for this supplement, but first I would like to briefly talk about why it's important to engage with youth in research and programming activities that ultimately impact them. With that being said, it's important to look at our perceptions of young people and to know that young people are assets and should not be simply viewed as lacking capabilities or being deprived of circumstances. Young people are innovative and creative in problem solving and solution finding. USAID's Youth and Development Policy calls for young people to be supported to create an environment where young people can voice their opinions and in return be productive and engaged citizens. And I decided to include the Youth and Development Policy just to show the idea that youth engagement is something that is institutionalized and important to USAID. So essentially we are trying to walk the walk and also talk the talk when we're discussing youth engagement. And now let's talk about the benefits gained through youth engagement by youth. Okay. All right. In addition to engaging youth because they are an asset, the practice of engagement can also build skills and competencies youth need to succeed in their transition to adulthood. So youth engagement has a number of personal benefits, including increased self-esteem and sense of control and identity, development of life skills, leadership and civic responsibility, academic achievement, and a decreased involvement in negative risky behaviors. There is also strong evidence that youth engagement supports positive mental health. An engaged citizen is making healthy connections with peers and supportive adults. And youth are not the only ones that are benefiting from this form of engagement. There are also benefits for both adults, communities, and organizations. So some of the benefits for adults, communities, and organizations include positive perceptions. Communities and organizations that engage youth have greater awareness of young people's needs, capacities, and aspirations. Over time, meaningful participation can change how adults see young people, ultimately changing their perceptions to looking at them as a resource rather than a problem. And then, youth are innovators and can bring new energy and creativity to an organization. Youth engagement benefits the society by establishing a generation of informed, active, and committed youth to take development forward into the future. And lastly, although research is limited, experts believe that engaging youth in the design and monitoring of development projects have a positive impact on programming. And so now that we have outlined the importance and the benefits of youth engagement, we can look at our specific youth review process for this supplement. So the first step that we went through was we created a call for youth reviewers. Through our YouthPower Action contractor, FHI 360's various country offices, partners, and the YouthPower Youth Engagement Community of Practice, we identified potential youth reviewers in countries and regions. Let me repeat that again. So through our YouthPower Youth Engagement Community of Practice, we identified potential youth reviewers in countries or regions represented by the articles submitted to the supplement. And so next we assigned each of the youth reviewers to a supplement article. And this was based on the region or country in which they lived in the topic area. The youth reviewers were also paired with one of the supplement editors to mentor them through the process. And also I'll just mention for the youth reviewers, we ultimately picked 9, and 3 of them were from the United States, and then 1 each came from Botswana, Tanzania, Uganda, Kenya, South Africa, and Zambia. And that's how we got to our 9. The third step was that we disseminated the youth review template to all of the youth reviewers. And as supplement documents to the youth reviewing template, we sent instructions for the youth reviewers on how to review and actually fill out the template, and also 2 articles that provided background information on how to review a research article. Some of the guided prompts on the review included statements or questions such as, how does this work inform HIV programming for young people? Does the study build on and address gaps in existing knowledge? How does this research study address important concerns for youth in the target population? And also, in the conclusion section, we wanted them to state any conclusions that can be drawn from the data being given. Fourth step was that we convened meetings with the youth reviewers and the supplement editors. And during these meetings, the editor and the youth reviewer would discuss the review and identify any salient comments that should be included for feedback into the author. And then lastly, we incorporated the youth reviewers' comments into the supplement articles. Sorry. And then the reception from the youth review process overall from both the youth reviewers and the supplement editors was very positive. From the youth reviewers' point of view, many mentioned that they gained experience participating in a scientific review. And personally, as a youth reviewer myself, my personal thoughts mirror the reception that's outlined on this slide. I gained invaluable experience working with Dr. Verman and talking through the supplement article that I was assigned. And I feel that I have a more rounded point of view and increased confidence when it comes to reviewing and implementing a journal review process and also giving critical feedback to colleagues. And then lastly, as outlined on the slides, the editors also appreciated the critique of the articles from a youth perspective. And overall, having this additional perspective helps strengthen the feedback given to the authors. And lastly, I just wanted to give a quick shout out and a thank you to all of the youth reviewers who volunteered their time helping us with this process. Thank you again. And then also a couple of quick other additional thank yous. I wanted to say thank you to my colleague, Dr. Rachel Golan, for her work, YouthPower Action, YouthPower Learning, the editors, and all of the authors for their contributions overall to the supplement. And then hopefully this overview has given you an increased understanding of why it's important to engage youth in researching and programming activities, and also insight into our specific youth review process for the supplement. Thank you, and we'll turn it back over to Julie.
Great. Hello, can everyone hear me?
Yes, we can.
Wonderful. Thank you, Calvin, and it's great to be part of this webinar and to also follow Calvin's great introduction to the value and importance of engaging youth. And I'll now share with you our experience engaging youth in developing an implementation science research agenda. And I'd first like to acknowledge the co-authors on the AIDS supplement manuscript. This was a Project SOAR activity, and Project SOAR is a USAID-funded project that's led by Population Council in collaboration with a consortium of partners. And many of the co-authors on the article are from that consortium, and we also have some co-authors from UNICEF, the Desmond Tutu Clinic in South Africa. But I'd also like to highlight that we have two youth advocates who were also co-authors on this paper and part of this process from the beginning to end, which was an exciting thing for all of us. And I wanted to share with you just briefly, I'll be talking about the Project SOAR's Technical Advisory Network meeting they held on adolescents living with HIV, and specifically how we engaged youth living with HIV in this process of developing an implementation science agenda, and the lessons learned and ideas for moving forward. The USAID Project SOAR two-day meeting was really about collective commitment and collective action. We pulled together 50 experts in the fields of HIV and adolescents living with HIV in sub-Saharan Africa. The meeting was held in February 2016, and we were able to draw in researchers, policymakers, funders, program implementers from, within the U.S. as well as globally. And most critically, especially for this conversation, we were also able to engage 4 youth living with HIV, 2 from South Africa, 1 from Botswana, and 1 from Zambia. And the purpose of this meeting was to really take stock of where we are now, what we know about adolescents, and we're talking about 10 to 19-year-olds living with HIV in sub-Saharan Africa in terms of their outcomes along the HIV care continuum, and also, more importantly, what do we need to know? What research questions need to be answered in order to improve their care and treatment outcomes? And when we talk about the care continuum, we focused on 4 areas. One was the testing and linkaging to care for HIV-positive adolescents, which is the focus of the AIDS supplement, as well as retention to care and ART adherence and viral suppression, and then this transition to self-management in adult care as an adolescent grows up. And so now I'll turn to how we engaged youth. And of course, first we had to identify the young people and determine the characteristics. This meeting was held in Washington, D.C., so we realized that while the meeting was focusing on 10 to 19-year-olds, we actually, having a minor travel by themselves or having a minor need somebody to travel with them added some complexity to it. So we chose to focus on youth who are 18 and older, and definitely were comfortable discussing their HIV status because they were going to be talking about living with HIV in front of a group of 50 people. And we reached out to our consortium partners and also experts invited to the meeting to identify youth to come. And we had, out of the 4 youth identified, 1 had prior involvement in international travel and attending an international conference, where the other 3 had never traveled and participated in a meeting like this before. So it was really fantastic to see them as they went through this process. And because of this, we also had the youth come to Washington, D.C. a day early so we could have some preparation meetings with them. We wanted a chance to talk with them, hear some of the highlights that they wanted to share at the meeting, address any concerns they have, and also just to give them some insight into what a public health meeting might be about. It's one thing, we often use public health language like target groups and different concepts that sound and feel different when you're part of that population. And we wanted youth to feel comfortable and to know what they were going into. And it was a really great bonding experience. Then at the actual meeting itself, we began the 2-day meeting with a youth panel where the youth were able to highlight what they felt were some important pieces that the programmers and researchers and funders and policymakers needed to know about what it's like living with HIV when they were adolescents. And they often spoke about learning their status and navigating care, disclosing to others, navigating school. And this really set the stage for the 2-day meeting. And after they spoke and we had time for discussions, we had some other experts talk, and then we spent the rest of the 2 days in working groups. And these working groups there were 4 of them, and they corresponded with the care continuum. So we had a working group on HIV testing and linkages to care, and the other, retention to care, adherence, as well as transitioning to adult care. And youth chose to participate in the transitioning to adult care working group. And it's in these groups where they developed their implementation science research questions. And once those questions were developed, we came back as an entire meeting group where each of the care continuum segments presented what they determined were the top 6 questions, implementation science questions that we need to answer. And then the entire meeting participants, we held a silent voting process where we could vote and prioritize the top implementation science questions, and the youth were part of that voting. And then at the very end, we actually ended with a youth panel where we had an opportunity to hear from the youth how their experience was in the previous 2 days, what their thoughts were on the implementation science questions identified, and just a chance to kind of wrap up with their voices. And as one 18-year-old participant said, HIV has been a curse and a blessing. If it wasn't for HIV, I would never have met Desmond Tutu or traveled to Washington, D.C. to be at this meeting. And the speaker volume is actually on high, so I apologize. Is this better? I'll try to speak a bit louder. Sorry about that. I also wanted to share with the audience just briefly that if you go to the AIDS supplement article, you will actually find those priority implementation science research questions for each of those care continuum areas. And these were really informed by that youth panel that set the stage for the conversations the working group had. So in terms of lessons learned, and I'm going to echo Calvin here, is that youth engagement definitely strengthened the research agenda setting process. Oftentimes, youth aren't engaged in that aspect of our programs and research, actually identifying what questions we have on how to improve programs and scale up. It also built the capacity of youth, which also Calvin was talking about in terms of self-esteem and other aspects. One young person said, meeting about adolescence are usually held without adolescent participation. This meeting gave me the opportunity to be heard by others from around the world. And one of our participants shared with us afterwards how it really gave her a sense of empowerment to discuss issues with other youth living with HIV in her home country. I also want to highlight that at the Project SOAR meeting, we really had youth engaged in the process, and we gave them space so their voices and their thoughts and their contributions could be made to the meeting. But they weren't involved necessarily in the organization of the meeting. But as an outgrowth of that process, we had a subsequent AIDS 2016 satellite session held in Durban that was led by one of our youth who participated, Katlego, and there's a picture of her on the right. And I'm hoping if you're on and listening, Katlego, please chat and say hi, and we would love to hear from you. Another one of our youth also was a speaker at the international conference. And the two youth who didn't speak at the conference, they also said how empowered they felt just seeing their peers up there talking and sharing their experiences. So we also had a form that they filled out that gave them an opportunity to write out their comments for youth. I just want to highlight two. One says, please involve me when making these policies, and the other person said, create more opportunities and platforms for all youth who want to be involved to contribute their time and abundant need to have selfless purpose. So in reflection, when we think about youth engagement, we really need to think about meaningful involvement. And as I said before, the Project SOAR meeting did involve and engage youth in the process, but we can think about youth kind of moving them from beyond just beneficiaries or engagement to actually leaders helping us with the epidemic. So thank you very much.
Okay, thank you. Thank you, Julie, and thank you, Calvin, for such important words on looking at how to meaningfully involve youth in both interventions and the design and research agendas. I can only second everything that you both have said. I was involved in the WHO adolescent testing and counseling guidelines, and at the time they really took a lot of efforts to involve youth and adolescents in the design of those guidelines, and it led to just a stronger product in the end. So appreciate it. Our next speaker is going to be speaking to voluntary medical male circumcision among adolescents, the missed opportunity for HIV, behavioral interventions, and we're going to be hearing on that from Dr. Michelle Kaufman, an assistant professor at Johns Hopkins University School of Public Health. And Dr. Kaufman is a social psychologist by training and studies how interpersonal relationships and social factors contribute to health disparities and how behavior change interventions can help to mitigate these factors, critically important in the field of HIV. Her work focuses on how gender roles, sexuality, and social status put individuals at risk for poor health outcomes. So with that introduction, please, Dr. Kaufman, begin.
Thank you, and thank you for the invitation to participate in this webinar. Yes, I'm going to talk about a component of a study we did in 3 countries where we looked at the voluntary medical male circumcision service delivered to adolescent males. So if you're not familiar with VMMC, as we call it, this is a HIV prevention tool that reduces heterosexual acquisition by up to 60% and also reduces other STIs. And we know this from 3 randomized trials conducted in Kenya, Uganda, and South Africa, and more than 40 observational studies. WHO and UNITAD both recommend VMMC in countries with low circumcision rates and high HIV prevalence. Scale-up initiatives around this intervention have resulted in over 11 million VMMCs as of the end of 2015. And most of the clients to date have been 10 to 19-year-old adolescents, although that group has not been specifically targeted. But we know little about the quality of VMMC counseling and the health service delivery for these young males. So there are 6 key elements that PEPFAR and WHO recommend for complete VMMC service provision. These include HIV testing and counseling, education regarding the benefits of VMMC, procedure details, so what will actually happen during the procedure, then conducting the procedure itself, followed by instructions on how to care for the wound, and then counseling on other HIV preventative behaviors. So to prepare for our study, we did a review of sexual and reproductive health service provision for adolescent males and found that service providers seem to lack a commitment to serving young clients. Some studies pointed out that providers rush through appointments. There's a lack of privacy and confidentiality for these young clients. And there were reports that providers demonstrate little respect for youth. And this is all summarized in a paper we published last year in PLOS One. But we don't really know if VMMC providers in sub-Saharan Africa address the specific needs of male adolescent clients. So given these findings, we wanted to explore whether the service provided to adolescents specifically meets their unique needs. So the goal of this study was to understand whether VMMC programs adequately meet adolescent needs in ways that are appropriate. And we did this by exploring the counseling, the communication, and the client-provider interaction, and then looked at differences by age. So we assessed adolescents ages 10 to 14 and the types of service they were receiving and the types of counseling, and compared that to 15 to 19-year-olds. And then ultimately, this work will help us to develop recommendations for strengthening VMMC guidelines to ensure that education and counseling are appropriate for these adolescent clients. So we collected data in 3 countries, Tanzania, Zimbabwe, and South Africa, and collected a range of mixed methods data, in-depth interviews that included male clients and providers. We conducted focus group discussions with parents and male adolescents who have not received circumcision yet, and also female peers of those males. We conducted key informant interviews with facility managers, and then we did pre- and post-procedure surveys with adolescent clients themselves. So for this presentation and the paper that appeared in the supplement, we focused only on the in-depth interview data with male clients and providers. So the interviews were audio recorded, they were transcribed, translated into English for coding and analysis. We had 2 coders who independently coded the data using Atlas TI software. So I want to focus on the adolescent perspective of the service and counseling they received, as well as the provider perspective. So from the adolescent client perspective, they reported that there was limited information given to them on the HIV testing process prior to the VMMC procedure. Oftentimes, these adolescents reported that they would have varied explanations of what HIV testing actually was. Some of them reported that they had their blood drawn without knowing why. Others said that once the provider gave them a clear explanation of the importance of HIV testing, that they understood why this was part of the service. So here's an example of a quote from a young male in South Africa who said, he, meaning the provider, said, if you want to circumcise, you must do the test first. And he told us that if you're HIV positive, you're not allowed to circumcise. He told us that the reason they test us is to see if we are HIV negative, and then they circumcise us. He explained to us the importance of getting tested for HIV until we saw the need of doing it. But it should be noted in this example that the adolescent client believed he needed to have an HIV test to receive VMMC, whereas the WHO guidelines state that HIV testing is to be offered to all clients, but is not mandatory in order to go forward with the procedure. Also, from the adolescent client perspective, many of those who participated in interviews said that they were not told about HIV transmission during vaginal sex. They didn't really understand well the link between VMMC and partial HIV protection, particularly the younger clients. And then in terms of receiving counseling on further HIV prevention behaviors, these young adolescents in particular didn't receive messages regarding the importance of condom use. And this really varied by age range and the specific provider that they worked with, but only 6 adolescents out of those we interviewed reported actually receiving condoms to take home with them, despite this being a recommended part of the VMMC service delivery. So here's an example quotation from a 15-year-old male in Zimbabwe who said, "She, the provider, said we were still young, so we were not supposed to use condoms nor have sex. We have to wait until we are 18 years old." Then another young male in South Africa said, "She, the provider, said we must not have sex with females, especially as we are still young, and she said there's no need for condoms." So you can see that some providers assumed that these young males were not engaging in sexual activity, nor were interested in it, and decided not to include that as part of their counseling experience. So from the provider perspective, these providers said that they did provide limited information about HIV testing and the process involved in that. They said that with younger clients in particular, they tended to give less detail about HIV prevention, and that they based their counseling content on the perceptions of whether adolescents were ready for sexual health information. In Tanzania, in particular, providers talked about letting the knowledge and sexual experience of the client guide the discussion in terms of HIV and its relationship to VMMC. But in South Africa, we found from these interviews that providers seemed less hesitant to discuss HIV prevention. And they said that they felt this way because children are often learning about HIV at a young age in schools. But this openness about talking about the details of HIV, particularly sexual transmission, was tempered when parents sat in on their counseling sessions, as they often do with the younger males. So here's an example of a quotation from a provider in Tanzania who said, "I tell them," the 10 to 14-year-olds, "about the partial protection from HIV, from circumcision, but I don't put emphasis on sex. I tell them that they already have a 60% protection from circumcision. But if they do things such as picking up used razor blades or sharp objects, they could still be infected." So this is a good example of how providers were talking about HIV, but were really leaving out the sexual components of it. Another issue that came up for providers were challenges regarding HIV disclosure. For young males who did test positive, it was challenging for the providers we interviewed to tell them that they had a positive status and then provide appropriate linkage to care. Many of the providers we interviewed said that they really don't have the skills to be able to reveal a positive status to such a young male or to engage in the referral process. One provider in Zimbabwe said, "Except when the child is positive, that is when we involve the parent. But when we are giving out results, we say, 'Your blood is clean,' which means a lot to many. So he will go and say, 'Mommy, my blood is clean.' If you say clean, they will understand that they are negative." So this provider found it much easier to talk about what it means to be HIV negative by saying your blood is clean. But when involving the parents, sometimes they would wait until the parents were able to come to the clinic, and that often resulted in delaying treatment for these young clients who are HIV infected. So in summary, through our study, we saw that VMMC really presents a missed opportunity to fully inform a generation of young men about engaging in HIV risk reduction and build their behavioral intentions for the future. The counseling that these young male clients are receiving seems to be suboptimal, especially for the younger adolescents under age 15. There's also inconsistency with sharing HIV test results with the clients, and incomplete information is being provided about other forms of prevention, particularly condom use. So some implications from this research. One is that counselors clearly require training in how to counsel adolescents who are infected with HIV and how to link them to care, and whether to offer the VMMC service to these individuals. Second, VMMC may be more effective in providing complete HIV prevention and care messaging if all adolescents are given age and sexual experience appropriate information. And finally, strengthening VMMC counselors' interpersonal communication skills really requires guidelines and further training so that they are able to address the full range of needs that might come about for adolescent clients. So I just want to acknowledge the technical advisory group that was instrumental throughout this entire study. And they were individuals from all of these organizations. And most importantly, our in-country teams, as well as our partners at USAID, and then our team at Johns Hopkins University. Thank you.
Okay, thank you, Dr. Kaufman, for those really important results on looking at ways we can improve the quality of our VMMC programming and targeting adolescents. I do wonder as well whether we could extrapolate those results to a lot of other settings. I can imagine we'd find similar findings in both HIV testing and in clinical care, but really, really good to see this documented and potentially addressed. Okay, we're going to move on to our next talk. This one's going to be on HIV self-testing, a very hot topic at the moment. WHO has just pre-qualified the OraQuick HIV self-test, so this is going to be an approach that we'll be expanding. We're going to hear from Pachaya Indravud, who's a research associate at the Malawi Liverpool Wellcome Trust Clinical Research Program, and is the Malawi trial coordinator and lead for gender analysis under the UNITAD PSI HIV self-testing Africa or HIV-STAR study, a multi-country implementation research project of HIV self-testing, which is beginning to show some promising results, and we'll see some here. So take it away, Pachaya.
Petra, I think your sound is cutting out. We can't hear you right now. Try disconnecting and reconnecting your audio. Yes, your audio cut out there. You might just want to repeat this slide.
Okay, thank you so much, Pachaya, for providing us with those really interesting results. I think as we see self-testing beginning to scale and expand, we're going to really need to think about how we're designing the interventions to reach the populations of interest. And in this case, looking at adolescents, there are really some specific things we can learn from it. So, not only in the outcomes, but also in the process. So, very, very nice presentation. There's a rich discussion happening in the chat. So please, if you've got questions to these or any of the topics we're discussing today, or perhaps even others related to adolescence and the first 290s, enter them there, and we'll get to those once we finalize the presentation. We're going to move on to Dr. Andres Camacho-Gonzalez, who's going to be presenting on the McCarthy study, Closing the Gaps in HIV Care Among Youth in Atlanta, Georgia. Dr. Camacho-Gonzalez is a board-certified pediatrician and pediatric ID specialist. He directs the Pediatric ID Fellowship program at Emory University School of Medicine, and his clinical and research interests focus on the delivery of HIV care across the spectrum of the care continuum. So please, Dr. Camacho-Gonzalez, take it away.
Andreas, can you connect your mic? Andreas, is your mic icon at the top left part of your screen green? Andreas, you might need to exit and re-enter the room if your sound is disconnected. Sorry, everyone, for this delay. Andreas, you've made your presenter again if you want to try reconnecting your mic. Andreas, do you have a mic or telephone icon at the top of your screen? That's all you need to click is just the the icon, the mic or telephone icon to connect your audio.
Top left hand side.
Yep.
Hello? Hello?
I heard something.
Hello, can you hear me?
Yes.
All right, good. Thank you. Sorry about that. Thank you, Vincent, for your introduction. And I'll be presenting the McCarty trial, which is a non-traditional venue rapid testing, case management, and motivational interviewing to diagnose, link, and retain youth in HIV care. I've received research support from Janssen Pharmaceuticals and Gilead, but I will not be discussing any off-label use or any investigational use in my presentation. So as many of you may know, Georgia ranked 5th highest in the nation for total number of new HIV diagnoses, with a rate of 12.9 per 100,000. 22% of people diagnosed in 2014 had AIDS within 3 months, and 11% of this new HIV diagnosis in youth was stage 3. There's about 40% of the infections that occur among adolescents and young adults between 13 to 29 years, and the majority of people are black and males, and from the males, 83% are men who have sex with men. Overall, CDC estimates that an American has 1 in 99 chance of being diagnosed with HIV at some point in their life, but that lifetime risk is greater for people living in the southeastern part of the United States. Specifically, Georgians have about 1 in 51 chance of being diagnosed with HIV in their lifetime, making the state the 3rd highest in the nation. If we looked at the continuum of care cascade, we can see how poor linkage there is between 13 and 24 years of age, with only 68% of them linking. And if we looked at viral suppression, we can see how people between the ages of 20 to 34 are only virally suppressed in 38% of the cases, well below the U.S. national HIV strategy goals. If we, youth in general living with HIV have a higher prevalence of psychological stressors contributing to unfavorable clinical outcomes and broader gaps along the HIV continuum of care compared with the HIV-infected adults. Singer's endemic theory suggests that healthcare is affected by multiple epidemics that should be addressed simultaneously. Adverse social structures such as poverty, discrimination, stigma, abuse, and psychiatric comorbidities increase risk for HIV acquisition and adversely impact adherence to HIV treatment. Therefore, effective interventions tailored to HIV-infected youth are urgently needed. We developed the Metropolitan Atlanta Community Adolescent Rapid Testing Initiative, which is a multi-pronged intervention that combines non-traditional venue HIV testing, motivational interviewing, and case management support to improve diagnosis, linkage, and retention in care of youth ages 18 to 24. The strategy in itself was created by youth, as the intervention started with a formative phase with focus groups of HIV-infected and uninfected youth to help us inform and develop a youth-friendly strategy. McCarty was designed as a pilot single-center prospective non-randomized interventional study, and enrollment occurred from December 2012 through January 2015, with follow-up through February 2016. Participants in the testing phase included youth ages 18 to 24. The specific aims of McCarty were to, 1, determine the feasibility and acceptability of HIV testing in non-traditional venues, and 2, to determine if the McCarty model improves linkage to and retention in care of newly diagnosed HIV-infected adolescents and young adults 18 to 24. For the rest of the presentation, we'll be focusing on the second aim, This is the McCarty study flow diagram. And as you can see, McCarty had two phases: the formative phase, in which we conducted focus groups with HIV-infected and uninfected youth to identify testing preferences and potential venues, and where we conducted ethnographic observation of the sites to confirm the eligibility of the venue. During the testing phase, our team went to the identified venues and conducted HIV testing. Positive participants identified during the testing phase were constituted the intervention arm of McCarty. The standard of care arm was recruited from participants who were routinely referred to our clinic from doctors' offices, ERs, etc. And the standard of care arm followed routine clinical procedures, which could include psychological support and case management. However, this psychological support did not include motivational interviewing, and case management was limited to providing referrals for housing, food stamps, and transportation as needed. All of the participants had follow-up for a year, and in which they received, if it was the intervention arm, they received motivational interviewing and case management. And all of them had ACASI questionnaires and CD4 and viral load testing at each of the study visits. The specific components of the McCarty intervention included, as we said, non-clinical venue testing, motivational interviewing, which is an evidence-based, person-centered counseling method aimed at strengthening one's motivation and commitment to change. Emphasis in the sessions is placed on facilitating a change talk, which is defined by any statement that expresses the disadvantages of the status quo, advantages of change, intention to change, or optimism about change. Each participant received 5 MI sessions. As you can see in the slide, 1 was before the test occurred, and then 4 sessions at intervals of 1 month, 3, 6, and 12 months post-diagnosis. Each session lasted about 30 minutes, and they focused on addressing ambivalence towards making positive health behavior changes, adapting psychologically to new HIV diagnosis, developing a feasible approach to medical manage HIV, and implementing strategies to maintain long-term health behaviors. In terms of the case management, we use a strength-based model that goes beyond accessing services. It empowers participants to identify their own needs in utilizing available resources and services. Our outcomes were improve linkage, which was defined as first medical care visit occurring within 90 days after HIV diagnosis. Retention in care, which was the number of complete, we looked at it as a number of complete visits over a number of total scheduled visits during 12-month follow-up. And we also looked at HIV clinical parameters, CD4 and viral load, although we were not powered to look at this. In terms of statistical methods, we use parametric and non-parametric approaches to understand the differences at baseline. We used inverse propensity score analysis to control for baseline study arm disparities. We use linear mixed effects growth models to evaluate the statistical difference over study visit in CD4 T cell count and viral load. So moving along to the result part, for the McCarty arm, we tested 430 arm participants and identified 49 as HIV infected for a positivity rate of 11.3%. Standard of care arm screened 62 and enrolled 49. 13 were excluded because they were not new to HIV care. During the time that we were testing, that was around 2013, Fulton and DeKalb counties, which are one of the biggest counties and where the majority of the infected youth and infected people are identified in metropolitan Atlanta, were reporting rates of 1%. This emphasizes the need and advantages of targeted testing. In terms of venues, we went to a lot of different places. However, the highest positivity rate was seen in nightclubs and street testing areas identified as high risk by ethnographic studies. These are the baseline characteristics of both of the groups. In total, we enrolled 98 participants, 49 in each arm. 85% were male, 91% were black, with a mean age of 21 years. 62% had high school education or less. 23% reported currently using drugs, 14% reported a history of abuse, 78% identified either as homosexual, bisexual, or queer. And although we had differences in the baseline characteristics of study participants, after propensity score analysis, we were able to balance all those differences between the McCarty arm and standard of care participants. If we looked at the baseline HIV characteristics of both standard of care and McCarty arms, we can see that compared to the standard of care arm, McCarty arm participants reported fewer AIDS-defining conditions, 20 versus 51%, and a higher mean CD4 count, 317 versus 197, indicating that the outreach was identifying youth at early stages of the disease. In terms of linkage to care, overall 63% of participants were linked to care within 90 days of diagnosis. However, linkage was significantly higher for the McCarty arm compared to the standard of care, with 96% of McCarty participants being linked within 3 months of diagnosis compared to 57% in the standard of care arm. Additionally, the median linkage time of McCarty participants was also significantly different from the standard of care. As you can see, the patients in the McCarty arm were linked in about 0.39 months versus 1.77 months. That was statistically significant as well. In terms of retention of care, McCarty arm participants had better appointment adherence compared to Hello? Hello, can you hear me? Hello? Hello?
Sorry, we were muted. Yes, we can hear you. Just repeat your last.
Okay. So in terms of retention to care, McCarty arm participants had better appointment adherence compared to the standard of care arm participants with 86% versus 77%. McCarty participants also had better adherence throughout each of the follow-up study visits, although it was only significant at 90 days. We also looked at the percentage of participants who attended 100% of the clinical visits scheduled, and 50% of the McCarty participants attended 100% of the visits compared to 26% in the standard of care arm, and that was statistically significant. If we looked at the clinical parameters, CD4 count, we can see that overall the CD4 count increased significantly within both arms. Additionally, CD4 counts in the McCarty arm were significantly higher at all study visits relatively to the standard of care. Similarly, estimates for viral load indicated significant decreases in both arms, with McCarty arm participants having significantly lower viral loads at 6 months and 1 year, respectively. Our study has several limitations. First, the study population reflected a convenience sample that was not identified randomly, and the study was conducted in a single site. Although results may not be generalizable, the HIV epidemiology in Georgia reflects the current U.S. epidemic. Additionally, our clinic is the only adolescent HIV clinic in Georgia, and we potentially access the majority of HIV-infected youth in Atlanta. Second, several differences in baseline characteristics were noted between groups. However, the propensity score analysis helped us control for difference in those characteristics. And although we didn't found significant differences in CD4 count and viral load trends, which suggest improved immunological recovery and viral control in the McCarty arm, our sample sizes were small, and larger studies are warranted to confirm this finding. So in conclusion, the McCarty intervention was successful in identifying new HIV infections among youth 18 to 24 years of age in Atlanta, in achieving high linkage and retention rates, and improving CD4 T-cell count and viral loads. All of these measures are consistent within the goals and standards of the U.S. National HIV Strategy. The combination of non-traditional venue testing, motivational interviewing, and case management has the potential to effectively decrease gaps for youth along the HIV care continuum. And I want to acknowledge my study team, the community partners that helped me throughout the process, my hometown institutions, Emory and Grady, as well as my funders, CDC, NIH, and the CFAR, the Emory CFAR. Thank you.
Okay, thank you, Dr. Gonzalez. So I'm going to turn it over to my colleague Donna from HI 360 to take us through some of the questions and discussion.
Thank you, everybody, for a very nice webinar. I think we had a very nice representation of different research and programmatic efforts that are being done in both the U.S. and in Sub-Saharan Africa. We do have several questions. The first one being from Paul Michelle being, the question is this: what is being done for VMMC in the Western Africa region?
Yeah, so the PEPFAR priority countries are all in Sub-Saharan Africa due to the low circumcision rates. There are higher circumcision rates in West Africa, so those countries tend to not fall under the priority countries.
Okay, thank you for that. The next question is for Prachaya. Can you explain, Prachaya, the question is this: can you explain, can the choice of countries be explained? Malawi and Zimbabwe are both economically challenged, so price could be assumed to play a big role in choice when so few resources are available in households.
Yeah, so the choice of country was, I guess, decided in part with our donor UNITAD, concentrating on Southern Africa, where much of the HIV burden is, and trying to see whether self-testing is feasible in such a, I guess, resource-constrained region. And right now we are working in Zambia, Malawi, and Zimbabwe, and then for the next phase we're planning to expand into, still within Southern Africa, but to South Africa, Lesotho, and Swaziland.
Okay. A follow-up question is, will you be testing, can you go down, please? Will you be testing secondary distribution models among youth for self-testing?
I think it is something that we are looking into. So we have finished our first sort of phase of funding, which looks at more direct distribution, and then in our second phase we're looking at secondary distribution. Mostly through partners from ANC clients as well as index cases. And then we are also exploring more youth-targeted models, so seeing the viability of providing self-test kits at universities. So I think whether we give a participant 1 or 2 kits is something we're hoping to be able to give them 2 kits, but still being figured out.
Okay, great.
Hey, Prachaya, since you're on and we're on the topic, this is Vincent again, and there was a comment that I thought was interesting from Anna, talking about the limitations of discrete choice experiments, and that you might only see a specific subset of preferences and not others that wouldn't have been asked for. And maybe you can just discuss, because not everybody may be familiar with discrete choice experiments, some of the limitations of that and some of the impacts that you saw within the HIVSTAR study. It will be interesting to hear your thoughts on that.
Yeah, definitely. So with the DCEs, the attributes, we don't include all possible attributes, but we find that what we do include are the ones that are most likely to affect decision making. So one of the results I didn't present is looking at people's likelihood that they're going to choose the status quo. So that third option that I presented. So if the choices that we present are not acceptable, then you would expect people to expect that more people would opt out of the services we presented, which really didn't happen. So that kind of confirmed that the attributes and the attribute levels that we included were things that were most likely to affect decision making. And while I think people are willing to maybe maybe accept subpar attributes in certain circumstances. I think the value of the DCE is being able to look at the different trade-offs between the attribute levels. So, for example, with accepting a kit through your intimate partner, there was a negative preference for that. So, trying to offset that negative preference with something positive in order to optimize uptake, and making sure you don't compound too many attributes with a negative preference. And I think that's more the value of the DCE, being able to look at trade-offs, and then also having the qualitative work there as well, just to confirm what we're finding in the DCE.
Okay, thank you.
Okay, so Prakai, I think we have one more question for you. It says, your findings let us know that oral swab test is the preferred method compared to a blood test. And the follow-up question is the current need for oral diagnostic tests being met, kits being met?
You're on mute, Pachaya.
Sorry, I think you cut out there.
Oh, okay. So there was a comment from coming in from Twitter. Thank you very much.
Sorry.
Saying that your findings found that the oral swab test is preferred to a blood test. And so the follow-up question is the current need of oral diagnostic kits being met?
So I think that there actually wasn't. Did I hear you correctly that oral tests are preferred to blood-based tests?
The oral swab is the test preferred to blood compared to blood tests.
So that didn't come out as strongly actually in our findings. I think that people when they talked about the different collection methods, the specimen collection methods, that they were able to kind of weigh the pros and cons about each, so that oral fluid is, the oral swab test is more easy to use, but also recognizing sort of the benefits of the blood-based self-test as well. So I don't think we were, that finding came out as strongly, but we are, part of one of the studies that we're doing in the future is providing an oral and a blood-based self-test together and trying to see what people's preferences are based on having the two options actually available to be able to look at this a little bit more.
And I'll jump in and add one comment to that, and that is, I think that your paper was specifically looking at client preferences, but there is also a kind of a programmatic preference in that the oral fluid tests tend to be less sensitive in the early stages of infection. So depending on the incidence of your population, there may be more programmatic reasons that you'd want to look at blood-based tests. Now, there is no blood-based self-test yet, but there are a few in the pipeline, and when those come online, I think there will be a broader discussion around the appropriateness of the diagnostic for the population we're trying to reach. Just as kind of an added comment.
Okay, good. So Andres, we have a few questions for you. The first question is, can you tell us what the testing venues were in the McCarty trial?
Sure. So we tested in multiple places. We went to nightclubs, parks, bars. We were in the streets that were identified by the focus groups to be high incidence areas of prostitution and homelessness. Although the majority of the positive tests came out from nightclubs and street testing.
Okay, nightclubs and street testing. Okay, great. So this is a question to Donna and Vincent. It says, it's not often that youth reviewers are invited to participate in publishing journal articles and supplements. What is your advice for authors and editors who may like to involve youth reviewers in the manuscript process?
Well, as an editor, I'll let you respond.
Okay, so I will say that this was, we did not plan for it initially. It was a suggestion as we were working through the supplements and revising the articles. And it was a very thoughtful suggestion that we had to think a little bit about how to incorporate it. So I would definitely recommend it because as one of the editors on the paper, people bring different perspectives as you're reading things. And we really tailored the feedback we wanted for youth to comment more about how they think, how these findings resonated within their settings. And given that I don't live in Malawi or Zimbabwe or all these other places, it was very good to hear about programmatic implications. I think it was also interesting in one of my discussions with one of the people I interviewed, she actually shed light to me about the context in Zambia where she was involved in work I wasn't aware of. So I think that it's very helpful. We did some, and I want to give a shout out to Kate Murray, who really who worked on this from FHI 360, who did a Herculean effort in developing, with the support from USAID, a form to elicit the sort of targeted feedback we'd like. So I felt that was very helpful as well. I mean, Calvin, do you want to add a little comment to that about the form we developed and the feedback we were trying to solicit?
Yeah, I mean, I definitely agree with everything that you said about. So yeah, I definitely agree with everything that you just said, Donna. I was just going to add in just a quick piece of advice: is just like be deliberate about like your decision making if you want youth to be involved, and it would take a little bit longer to kind of think about the process and how to incorporate youth into whatever steps. But for our review process, we, like Donna said, like we kind of have like it took a lot of planning in order to think about how to actually strategically put youth into the process and where would it actually be the most meaningful for both the youth reviewers and also the editors. But I think I kind of mentioned like the questions that we put. It was a very similar to like what the actual each journal, their review process and like their questions. But we just actually wanted to add in more questions that we thought that we could get youth specific feedback on as well.
Right.
I'll add a comment and a question. So one was just thinking about this journal and the editorial, but I do think there's a role for, and as we look at all of what's been presented today, the role of youth and adolescents in helping to inform and design the programs that are serving them, right? And so we saw that initially with the supplement, but you also saw the appropriateness of the VMMC interventions for that population, the discrete choice experiment that showed specific preferences on how the design of the program would best reach them, and the McCarty study. And I'd actually, I turned this into a question for Dr. Gonzalez because you didn't speak much about the pre-phase of the trial in which you sort of did some focus group discussions. And maybe you could elaborate a little bit on how that part of the process informed the design of what it is you subsequently did in the intervention, because I think that connection is important.
Sure. So we, in conjunction with our community partners, we did about 17 focus groups with HIV-infected youth. Some of them were from our clinic. Some were from other community partner clinics, and as well as HIV negatives. And things that, in terms of the intervention itself, that we kind of the focus groups were handled to address different issues, but in regards to the intervention, we sort of wanted to understand what sort of the preferences of youth on how to test them, how to approach them for testing, and how to deliver the HIV diagnosis if the test was positive. So with their help, we sort of formulated this, also which kind of testing they would like, and the reasons behind it, and with their help, we sort of developed the entire intervention. We went to the venues wanted us to go and test. We didn't choose all of them because, you know, for privacy issues, there were some that we couldn't do. So we always looked at venues that could offer us a place to test that was private enough for people to be tested. But none of the, we didn't self-impose the venues. They just told us, and we went, and we had a big list of places, and we went and looked at them and sort of and spoke with managers and people in the venues to see if they were willing to have an intervention done in that area. And then based on privacy, we selected them. In terms of testing, there was it was sort of a 50-50 split between the oral swab and the INSTI test that is sort of a 1-minute test that is a finger prick. And since we wanted to include the motivational interviewing part as part of the intervention prior to disclosing the diagnosis, because we felt we needed to prepare the participant, or they wanted us to prepare the participant for either is it positive, this is what we're going to do. If it's negative, this is what we're going to do as well. But they wanted that information prior to the disclosure of the diagnosis, because they felt that once you tell the diagnosis, they cannot hear anything else. So the use of motivational interviewing prior to the disclosure of the diagnosis was in part to prepare youth for, you know, if it's positive, this is what we're going to do. So when you tell them that it's positive, we can go back to that session and say, well, we already discussed this, and this is our plan, and we sort of accompanied youth throughout that process. And then for the, and they were very clear that they wanted a plan of action that was sort of a positive plan of action, not that this, you know, this is it and you're going to die from this. They didn't want to hear any bad news at the time, except for you are HIV positive, but they wanted to hear sort of a direct approach and very specific approach of what the plan was going to be to address their diagnosis. And so with those elements, we built the intervention, and we decided to include the motivational interviewing part prior to the diagnosis to help, because basically they were the ones building their plan. We sort of, you know, as you do motivational interviewing is the participant sort of wanting to do or their willingness to do certain things. So you work with them to guide them through that, and that's how we build in the intervention.
Great, thank you.
Does that
absolutely in detail? Thank you so much.
Hi, I'm hoping people are following. We're having a pretty interesting chat about self-testing. One of the questions, there's a comment by somebody saying I worry about adverse psychological, reactions to people because of self-testing, and there's a thoughtful comment back saying, this is mainly a reaction to being positive, not actually the self-test itself. But I wonder if Prachai, you have any more that you'd like to add to this conversation about self-testing. And I think there's this follow-up question for you, Prachai. Can you talk about how youth were involved in the design of your in your study in terms of the self-testing strategy, rolling out the intervention of self-testing?
Yeah. So for the first question, so we did some. I mean, we're really interested in potential for social harms as well, and we did do focus groups specifically focused around social harms and how they could be prevented or mitigated if they do happen. And I think just looking at it without the kind of before the trial was happening, I think there was very kind of little anticipated social harms that were coming out from young people. I think that to address any social harms that came up, I think that's why the preference for some form of counselor or even the distributor, just having them nearby and available in case any concerns do come up related to a positive self-test come up, that they're able to easily access them. I think we find in our trial so far, which is on community distribution of self-test kits, that a lot of the people who receive a self-test have a very good relationship with the community distributor and help them to kind of address any issues that they might have. I think it's well established in previous studies as well that there is little incidence of social harms. There are I guess one thing that does come up is certain dynamics around coercive testing, but finding that most people end up being okay that they tested in the end and being happy that they tested in the end, regardless of it being perceived as coercion. And I think that with this set of trials and studies that we did, we just based on our timelines and delays in funding, that the aim was to have our formative research kind of inform our trials, but I think with these sort of findings that we're having with young people, we'll have them inform our trials in the next phase.
Okay.
Definitely.
And could you speak a little bit about how youth were involved in the trial you're working on?
Just to say that because of how the studies worked out for this phase, we weren't able to engage them directly, though we are partnering with PSI for our implementation, and they do a lot of marketing research around consumer preferences. So they did do that more kind of market research around young people and sort of target profiles around certain consumer segments. And I think in terms of our research findings, kind of more these results that we have here and engaging young people, we will definitely use that to feed into the trials, as well as create other kind of participatory approaches to including them as well. So for the next phase, we're hoping to have some more participatory workshops around these key groups that we're interested in including young people and men.
Great, thank you. We had a comment about Liberia, wanting to know if there are plans to do similar types of research in Liberia. And there has been actually some research done in Liberia about the needs of young people regarding HIV, who are at risk for HIV. And I worked on a study, and I'm happy to share this link with everybody that was done in Liberia. We used the place methodology in Monrovia and that county to identify, understand the drivers of the HIV epidemic, and we also did look at HIV testing. I just pulled this up. It's available online. It's an open access article. But similar to what we find here, we found in this study that many young people were engaging in transactional sex. And of those people who, and we also found low rates of HIV testing, both for young females and young males, with females having slightly higher rates of testing at about 21% of those we surveyed, as compared to females, which had only 15% of testing. So I think and this study was done with support by UNICEF, and we presented it to the Ministry of Health for planning efforts around the need for young people at risk for HIV. So I think we just sent that link. So thank you for that question in Liberia.
Okay. So thank you, everybody, for joining. Thanks to the presenters. I'll wrap up with a couple of comments before going into the appreciations. But I think what we saw initially, I tried to lay out some of the issues around the demographic shift, the epidemiology, and the gaps that we're seeing in particularly the first two 90s, but all of them really compared to adults, and the attention that really needs if we're going to realistically move to any sense of epidemic control in the next 5 to 10 years. I think we've been focused on the clinical continuum, and the supplement is focused on the clinical continuum, but we certainly don't want to do a disservice and not pay attention to the prevention continuum. Most of the adolescents who test are going to be HIV uninfected, and those that are at risk need access to prevention interventions. We're seeing that within our DREAMS program, within PEPFAR, but certainly just more generally, this needs to be included in any HIV programming. The selection of papers that we saw presented here today really kind of presented a nice cross-section of the hows and the whats of the interventions to reach adolescents at risk and adolescents and young people who are HIV infected. We saw from Calvin and Julie a good representation of how we include adolescents in the design and the thinking of the programs that we're implementing. We saw within the VMMC context at least how the quality of that programming can and needs to be improved to address the populations that we're serving. And relatedly, through Pichea's work on self-testing and the preferences there, how we're going to be delivering self-testing to specific target populations to the most public health benefits. And then finally, Dr. Gonzalez gave a really insightful overview of the McCarty study, particularly the element of looking at how they're best designing their interventions with input from the populations that they're serving and the actual impact that had downstream in terms of diagnosing and getting into clinical care the adolescents that they're reaching. So I see some red threads going through all of the studies that were presented. There are probably twice or three times as more in the paper itself, and there are many more out there. This is just the tip of the iceberg in terms of building an evidence base, but it does more than that. It really kind of brings attention to the issue of the gap and the response that's needed to close that gap. So with that, I'll stop and really thank everybody who worked on the supplement. Donna and Kay from FHI 360, Calvin, Ryan Phelps, and Rachel Golan sitting here to my left, who helped really shepherd this through. It's been a tremendous amount of work over the past 12 to 18 months, and it's really been fruitful. Thanks to all of the presenters who took time out today, and thanks to everybody who joined. I know there were competing webinars. Thank you for choosing ours, and feel free to contact us as needed. We're happy to discuss anything and everything that we talked about here today if you'd like to.
Thank you.